Good evening and welcome to Doctors on Call. I'm Dr. Ruth Westra from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I'm your host for tonight's last program of the season on orthopedic problems and joint replacement. The success of this program is very dependent on you, the viewer, so please call in your questions and we'll do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Patrick Hall, an orthopedic surgeon with Orthopedic Associates of Duluth, Dr. John Redman, an orthopedic surgeon with St. Luke's Orthopedics, and Dr. Joseph Signorelli, an orthopedic surgeon with Essentia Health. Our medical students answering the phones tonight are Brian Berglund of Lauderdale, Minnesota, Peter Hughes from Mankato, Minnesota, and Bradley Nix of Melrose, Minnesota. And now on to tonight's program on orthopedic problems and joint replacement. So to just start the show, Dr. Hall, what are some things that people can do as we age and we have joint pain, maybe in our knees, before we get joint replacements?
Well, usually the onset of pain in the knees or hips comes from activity. And so people who have early onset arthritis tend to start having pain with activities. And so one of the things we oftentimes recommend for patients who come in to see us for the first time with joint pain, who maybe have a little arthritis in their knee, is to try some over-the-counter medications, anti-inflammatory medications like ibuprofen or Aleve, even Tylenol. A lot of people can get by with just an over-the-counter anti-inflammatory medication. If people don't respond well to those, there's some prescription medications that we can try. There's some prescription anti-inflammatory medications and painkillers. Some of the other things we do for knee and hip arthritis are injections. And there's a couple different injectable medications that we use for people who have arthritis in their joints. The long-standing injectable medication that we've used for a number of years is a steroid medication. We used a couple different kinds. Back in the old days, we referred to them as cortisone injections, but nowadays we use a synthetic type of steroid. Usually what we use in our office is Canalog or Depomedrol, but they just act as a potent anti-inflammatory agent in the joint, and so they can decrease the inflammation in the joint and lessen the symptoms. It doesn't reverse the arthritis or cure the arthritis, but it can lessen the symptoms and make it easier to function. Another newer medication, it's not so new anymore, is hyaluronic acid injections. And hyaluronic acid is a chemical compound that our bodies produce in our joints. It's part of the joint fluid that naturally lubricates our joints. And it's been found that an injection of hyaluronic acid into the joints can sometimes lessen the symptoms of arthritis as well. Back when it first came on the market, it was always done as a series of shots, usually about a week apart. And now some of the newer formulations are injectable medications that we just have to do once. So it's a lot less cumbersome for patients. They don't have to come in every week for an injection. So those are really the two injectable options. And so that's where we start. And if patients fail the conservative options, then we start to talk about some of the surgical options.
Well, Dr. Redman, we have some props that we brought along. Maybe you could talk about the knee, and we'll have Dr. Signorelli talk about the hip replacements that we have in front of us.
So this is an example of a total knee replacement. I don't know if I can lift this out of here, but essentially what happens to the joint when it becomes arthritic is the cartilage on the end of the bones gets destroyed and an inflammatory process takes place. And once that comes to the end stage, we remove the end of the bones and cap it off with these pieces. You can see here, this is the end of the thigh bone, the femur, which has a metal cap here. This is the top of the tibia bone here, which is capped with a piece of metal. And then in between that is a piece of plastic, essentially, that acts as a smooth gliding surface for the knee. And then many surgeons, probably most surgeons in the United States, cap the back of the kneecap as well with a piece of plastic that rides on the front of the femur. So that's essentially the crux of it.
Dr. Signorelli, do you want to show us the hip? Or we can slide these over here.
Sure. There's a model of the hip, and similar to some of the things that Dr. Redman was saying, the arthritis process that usually leads to the hip replacement is loss of the cartilage in the joint. The hip, a little bit different from the knee, is a ball and socket joint. So there's the ball in the socket, which is in the pelvis. And so a lot of what we try to do with the hip replacement is to restore the body back to the normal mechanics prior to the arthritis process. So for most conventional hip replacements, you can see through this translucent model, there's a stem that goes down the inside of the bone, which is a hollow bone, like a marrow bone. It goes on the inside of the bone. And in the United States, the majority of implants that are put in for the hips are put in without bone cement. So they go in and the bone actually grows into the implant and essentially becomes one over time. In the socket, we do a similar process where we replace the native or the normal socket with a round metal socket and insert a different liner of different materials depending on a patient's age and activity demands. And then the ball goes back into the socket and the hip moves around in a more natural fashion without the pain that they had prior to surgery.
Dr. Redmond, we have a caller from Duluth calling about arthritic knees, if the pain when people walk. Is that primarily the biggest reason, if we've done the things that Dr. Hall talked about, that people would have a replacement?
Yeah, I think the primary reason to have a joint replaced in the end is pain. And once you've tried all the things that Dr. Hall was just talking about in terms of conservative treatment, anti-inflammatory medications, injections, once all those non-surgical things fail, then we typically move on to considering joint replacement.
And a caller from Barnum, Dr. Signorelli, asking about age. Is there a certain age at which we would start replacements, or does that make any difference whatsoever?
That's a little bit of an evolving process. If you were to ask that question, say 10 or 20 years ago, the answer might be that you really should be in your 60s, late 60s, 70s, or even 80s before you have your joint replaced, because the fear is that it may wear out and need to be redone. But I think we're realizing as a profession over time that a lot of people get arthritis much earlier in life, and so we don't want to take away what a lot of people consider the prime of their life and tell them you can't be active, you can't do what you want now, and instead you have to put off those activities till later. So we're finding more, as long as you're a candidate for joint replacement, we think it will benefit your life, and if your quality of life and what you want to do and need to do is compromised, then age is less of a factor.
And Dr. Hall, asking about what kind of activities, let's talk about knee. Are there any restrictions after you have a knee replacement?
Yeah,
activities or exercises?
As far as exercise goes after a knee replacement, I usually tell my patients they can play doubles tennis, they can do some cross-country skiing, maybe some easy downhill skiing. I think some of the activities that we like to have patients avoid are some of the high-impact activities, like long-distance running and sprinting. And with certain knee designs, it's probably not a good idea to kneel frequently. So there are some limitations. These things have a finite life, and we try to recommend that patients don't do a lot of high-impact activities that might jeopardize the replacement or cause it to loosen.
This is an interesting question, Dr. Redmond from Hibbing, asking about elbow replacements. Is there such a thing as elbow replacements?
There is. There are much fewer elbow replacements done each year in the United States than there are compared to hip and knee replacement, but certainly the same arthritic process takes place in the elbow that takes place in the knee and hip and shoulder. And for patients that have pain limiting their function and quality of life, elbow replacement is certainly an option. The track record on elbow replacement is not quite as good as hip replacement and knee replacement, and it carries with it more restrictions. So people that end up having their elbow replaced typically have a weightlifting restriction that's forever. So but it is a good option for people with end-stage arthritis of the elbow.
Dr. Signorelli, a caller asking about knee clicking. After they've had a total knee, do you get you hear noises or anything after you've had knee replacements?
That's a good question. It's one of the hard things in what we do is to try to create the most natural feeling joint replacement, whether it be hip or knee, as possible. But when we're replacing cartilage and bone with metal and plastic, it's patients will occasionally have a mechanical type feel to it. There's a lot of clicking that can occur that, for the most part, ends up subsiding with time and doesn't end up causing any problems. If someone has clicking or popping or any sort of noise that's associated with pain, then it's something worth looking into.
Dr. Hall, a caller's asking about hip replacements and playing tennis subsequently. I thought that was interesting. What's any recommendations? Yeah,
I think it's okay to play tennis. I've had hip replacement patients return to playing tennis. I would probably recommend doubles tennis rather than singles if they're real aggressive tennis players. But tennis is one of those sports that's kind of in a confined area, and it's probably okay to do that.
Dr. Redmond, so this caller is asking if each doctor chooses their own brand of replacement, or are there only certain kinds, and how do we decide?
Yeah, that's a good question. There are a number of manufacturers of all types of joint replacement, and some hospitals will have contracts with certain vendors, and so surgeon's choice might be somewhat limited, but in general, it is up to the surgeon to determine what manufacturer, what product they're going to use. And I think some surgeons would be flexible in that if patients had a certain implant that they were interested in. But in general, we become familiar with the tools that we use at the time of surgery and have preferences.
And then Dr. Signorelli asking about different approaches. I know hip surgery has some different approaches that can be done. Can you talk about that a little bit?
Sure. I'll go back to the model for this one. Essentially, it doesn't make a whole lot of difference what way you get into the hip joint, but how the hip replacement's done, or it doesn't make a lot of difference in terms of what you use for components, but how you get into the hip joint I think does matter to some degree. So there's a lot of muscles around the hip joint. So this model here shows the clear structure representing the bone and the metal implants, but there's muscles that essentially envelop the hip. So there's a couple different ways to get into the hip joint. One of the larger muscles on the body, the abductor muscle complex, is attached to the outside of the pelvis. It attaches down onto this prominence of the bone here, so it comes down in a kind of a fan-shaped. One of the traditional ways to get into the hip is to divide part of the muscle off of the bone, do the hip replacement, and attach it back to the bone after the procedure. There have been some modifications to that with coming behind the muscle, with what's termed the posterior approach. And then a little bit of a newer approach to the hip is coming in front of the muscles in an interval where there's really no muscle in the front of the hip. So going with that approach, we're able to do the hip replacement without cutting any muscles.
And just a follow-up question, does one get better faster than the other, or does it make any difference?
Well, I think the important thing is in the long run, hip replacement is one of the most successful surgeries in medicine. So in the long run is really what we're looking for in these procedures. With that said, people seem to have a quicker recovery and less pain with the anterior approach.
Okay. And Dr. Hall, a caller is asking about Baker's cyst. Explain a Baker's cyst.
Yeah, a Baker's cyst or a popliteal cyst is a cyst that happens behind the knee. Usually, it's a common thing. We see it a lot with the advent of MRI imaging of the knee. We see a lot of those. A lot of times when people have a knee MRI done for another problem, an incidental finding is that they also have a Baker's cyst. Usually, Baker's cysts aren't symptomatic. Most people don't have symptoms from them. There's probably about 15% of patients that walk around with a Baker's cyst and probably don't even know it. So the Baker's cyst usually isn't the offending pathology that's causing the symptoms. A lot of times people have some other pathology in their knee, whether it's arthritis or a meniscal tear or some other process. And a lot of times those are the things that are causing the symptoms, and it's not usually the Baker's cyst. Sometimes if a Baker's cyst gets big enough and it starts to push on some of the other structures around the knee, and starts to cause symptoms, then sometimes we'll take those out or aspirate the fluid out to decompress the cyst. But oftentimes treating the intra-articular problem a lot of times allows the cyst to shrink and become smaller and less symptomatic.
Well, Dr. Redmond, a caller from Grand Rapids. So the question, why would they operate on the meniscus instead of the entire knee? Like, why do we do internal derangement surgery?
Yeah, that's a great question because it's such a common problem. As the arthritic process progresses, or sometimes due to an injury, there's a piece of cartilage inside the knee called the meniscus. And in an injury setting, that cartilage can be torn and become painful, and so that would be a reason that we sometimes operate on it, whether we fix it or remove the part that's torn. And then also patients sometimes with early arthritis will develop a meniscal tear, and that can sometimes be successful in relieving pain to go in and remove that portion of the meniscus. Now, if the arthritis has progressed to a point where people have significant arthritis, that operation becomes much less successful.
Dr. Signorelli, a caller asking from Kenyon about materials. We talked a little bit about that. Is there a difference between male and female, the type of materials that you would choose for replacements?
In general, it's more of an issue in knee replacement than hip replacement, and this is, I think, an issue brought on as much by some of the implant manufacturers as instead of a true need itself. There are some implants out there that are designed or marketed specifically for females or for males. They've done numerous studies looking at this, and I think having an appropriately sized implant is more important than having an implant that's gender specific. And all the studies that are out there suggest that there's no benefit to having a sex specific implant.
And does the weight of the person have a bearing?
It certainly does. There's again, good evidence in research studies that have been done that there's a trend that if somebody is over their ideal body weight, the implants tend to wear out a little bit sooner. It's a little bit like the analogy of treads on a tire of a car. And so the more you drive, the sooner it'll wear out, the tougher the roads, or if you're carrying a heavier load.
Dr. Hall, I have a caller asking about how long knee replacements or replacements will last. We may have touched on this a little bit, but
yeah, there's a lot of data out there on survivorship of knee and hip replacements, and most of the data runs out about 20 years. And for knee replacements with the newer designs that have been studied that long, there's probably about a 90% survivorship at about 20 years. I heard one of my old professors down at the Mayo Clinic was giving a talk recently, and a rule of thumb that he uses that I think is fairly accurate is that these fail about 1% a year. So for knee replacements, if you get out to about 15 or 20 years, it's about 15 or 20% failure rate by 20 years. And so that's probably a good rule of thumb. Now, we don't know how much longer they'll last beyond that because there hasn't been data beyond 20 years. Some of the implant simulators have gone out to about 30-year data, but that's not what's been done, seen in real life. And the other thing that makes it hard to study the survivorship is that the implants evolve over time, and we've made improvements to the implants over time in the materials that we use. And every time there's an improvement, you have to look at that improvement in the design and see if that makes the hip or knee replacement last longer. So the best data suggests about 85 to 90% survivorship at 20 years. So that's probably a good rule of thumb.
Excellent, thank you. Well, Dr. Redmond, we'll change topics just a little bit. I have a couple callers asking about bone cysts. Will you have any treatment for bone cysts, or would we just watchful waiting?
Well, they come in a lot of different varieties, and I think the key to, if you do have a bone cyst or an x-ray of the bone cyst, is you need to make a diagnosis as to what that cyst is and whether it's completely benign or worrisome, whether it needs to be followed. There are treatments for some bone cysts, particularly that occur in young people, but the key is knowing what it is and how to follow it.
And Dr. Signorelli, a caller from Duluth asking about ankle replacements. We're getting all the joints covered here.
Yep.
Can you talk a little bit about that?
Well, as you said, if there's a joint, somebody's tried to replace it at some point. With the ankle joint replacement, as Dr. Edmonds was mentioning with the history of elbow arthroplasty, the literature and the history is not as robust as with the hip and the knee replacement. But there's some very promising data, some of it coming from overseas, on different types of designs. There are alternative surgeries to ankle replacement that are sometimes less invasive and have a longer lifespan afterwards, such as fusing the ankle, which is not as much of a feasible option for the knee or for the hip. So ankle replacement is available. It's not used nearly as commonly as hip or knee replacement.
Thank you. Dr. Hall asking about gout in feet. Can you talk about that as far as any long-term damage that would occur because of that?
Gout is a condition that causes inflammation in the joints, and it's caused by a buildup of uric acid crystals in the joints. And when people have a high uric acid level, it can crystallize in the joints and cause an inflammatory response. And you hear it often in the feet. The most commonly involved joint with gout is the big toe joint. And so you hear a lot of people talk about their gout flare-up in the big toe. And that's treated with different anti-inflammatory medications. Over time, if people have repeated flare-ups of gout in a certain joint, it can do some damage to the joint and cause some destruction of the joint. So it's best to try to either treat the gout flare-up as early as possible, or there are some medications that can lower the uric acid level and hopefully prevent future flare-ups of gout. But gout can affect any joint, not just the big toe, but that's the most common.
Well, and Dr. Redmond, interesting caller from Duluth asking about, we've heard about glucosamine chondroitin. Can you talk a little bit about that? Maybe some comments from everyone about whether it helps or what's really going on with that?
There have been a lot of studies on that, on glucosamine chondroitin, and I think we've come up with different results. I think some of the best done studies that are out there have not shown a significant difference between glucosamine chondroitin and a sugar pill. But there are reports that it does help, and I think for patients, if it's not too big of an expense, I think it's worth trying. There does not seem to be a lot of side effects from the medication, and if it helps you on an individual basis, regardless of what the studies say, it may be beneficial. So I don't have a problem with my patients trying it.
Yeah, I'd agree. I think the literature has mixed results on the benefit of glucosamine and chondroitin sulfate. Those are two of the molecules that the body uses to build the extracellular part of the cartilage and helps to repair damaged cartilage. So the theory is that if you provide your body with the building blocks it needs to do that, that it'll do a better job and hopefully restore joint function. But I don't think it's ever been proven to reverse arthritis, or it hasn't lived up to some of the earlier manufacturer claims that it restores the joint height or the cartilage in the joint. So some patients in some studies have shown some promise that it's lessened the symptoms, but I don't think it doesn't really reverse the arthritic condition.
Well, Dr. Signorelli, one of the things we worry about are infections in all kinds of replacements that we do. What do we do to help avoid those?
That's a very important thing to discuss. That's one thing that I spend a lot of time in the office talking to patients about. That is the one thing that we are most concerned about for our patients after a joint replacement. If you get an infection in a hip or a knee replacement, it's different than an infection elsewhere in the body. You can't just take an antibiotic and it'll go away. It means that you really have to have surgery to get rid of it. There's a large collection of foreign material in a joint replacement which doesn't have blood supply, and blood is what brings the antibiotics to the joint. So we do everything we can to prevent it, which I think is the most important topic. Infection in joint replacement is really quite rare. It's about 1 in 200 or 1/2 of 1%, which is a low number, but if you're the one person that ends up with an infection, it's obviously a big deal. There's a rare situation where we have to go so far as to take the hip or the knee replacement out, put in a temporary replacement made of antibiotics, and then come back later to put in a new hip replacement. So that ends up being about 3 months out of someone's life. So again, prevention I think is key.
Pretty traumatic if you're the one. Dr. Redmond, we'll switch gears again. This is about dislocating shoulders and recurrent dislocations of shoulders. Is there any reconstruction that can be done regarding that?
There is, and that's evolved over the past 10 years or so. We used to do that through an open procedure. I think now for recurrent dislocators, the treatment can now be done arthroscopically, and a similar procedure that used to be done open, and there's a variety of procedures that can be done for a recurrent dislocator, but certainly it's become less invasive over the past 10 years or so, and it involves reattaching some of the ligaments in the front of the shoulder that help maintain the shoulder in the socket.
Well, we just have a couple of minutes, Dr. Hall. Now we've covered also finger joint replacements. I have a caller asking about the limitations of finger joint replacements.
Yeah, there are replacements for the finger joints, for both the MCP joints and the IP joints. That's a fairly specialized procedure. I don't do that procedure, but the hand specialists typically do that. But they have shown some promise, and the more common diagnosis is rheumatoid arthritis. A lot of rheumatoid arthritic patients get involvement of the finger joints, and it can be done. They're not done nearly as commonly as hips and knees and shoulders, but they can be done. And I think that if the patient has a problem with a joint and they need it replaced, they should probably see a hand specialist.
Okay. Maybe one more brief question, Dr. Signorelli, about heel pain and heel spurs Any suggestions for a caller regarding that?
Well, again, as we talked about for treatment for early arthritis, most of the time heel pain and heel spurs can be treated in a conservative or non-operative fashion. So there's different physical therapy protocols, different medications, different stretching, exercise programs, all of which can be pretty effective.
I have people always asking if they should have the heel spur removed. Any recommendations regarding that?
A lot of times the heel spur is more of an indicator of the problem rather than the cause of the problem itself. So getting to the root of it is often more effective.
Good. Well, thank you all very much. I want to thank our panelists, Dr. Patrick Hall, Dr. John Redmond, and Dr. Joseph Signorelli, and our medical students, Brian Berglund, Peter Hughes, and Bradley Nix. This is the final show of the season. Thank you for watching our program this season. We hope the information was helpful for your health and well-being. And remember, you can review all of our episodes from this season online at wdse.org. Good night.